Okay, good morning and welcome to the Insurance and Pharmaceuticals Subcommittee of the Health and Operations Committee of the House of Delegates. For those of you who are new to us and were invited to participate in this work session of the subcommittee, and we're invited with a Zoom link. And we will allow anyone who wants to speak on a bill inside the Zoom to speak, and you can let me know that you want to either ask a question or provide information using the reactions button and the raise hand function. So, and I will, like I said, give everyone time to participate. I would just ask you to keep your remarks concise and make sure that we have time to hear everyone. We do need to end by 11:55, if not before that, and we will use this time, particularly on the third bill. The first two bills we are going to vote on. On the third bill, we are using this as a work session to get information from the sponsor and others who know about the issue, and then we will be hearing this bill at during another subcommittee to see what we can do if we can get to a place where folks can support the bill as it is. So with that, we're going to move forward. And the first bill is House Bill 106. So Lisa, will you tell us what it is and what it does?
Sure. House Bill 106 alters the required composition of the board of directors of a nonprofit health service plan by requiring the board to include at least 11 members and no more than 21 voting members. It requires the two consumer members of the board to be covered by the nonprofit health service plan or its affiliates at the time of their initial election to the board. It increases from 4 to 5 the number of members of the board that may be licensed healthcare professionals, hospital administrators, or employees of healthcare professionals or hospitals. And it clarifies that the board must seek to include individuals with a diverse range of experience relevant to the mission of the corporation as a nonprofit health service plan. There is also one amendment in your packet, and the amendment increases from 2 to 3 the number of consumer members on the board.
Okay, thank you, Lisa. Are there any questions on this bill? Okay, seeing no question. Delegate Krebs.
Two questions. I'm assuming that who does this apply to?
Only to the Care First board of directors.
And it's just a comment. Before the testimony came out the other day, I was looking through this last week, and I was just on the record, I'm very disappointed in the fiscal note because it never tells you who it is. And your testimony was great, and Care First testimony was great. But when you read the bill and you read the fiscal note, it doesn't say this is right now, the only one it applies to is Care First in the state of Maryland. And I think that the fiscal note was a little bit weak. But I've explained that because I'm reading it thinking, okay, what's this bill about? And the average person reading it should know in the fiscal note that, hey, right now we have one of these and this is who it is. And it doesn't say that. So I think they got to do a little better job of that. But I just had a question on page 2, line 25. It basically says, to the extent possible, the board should seek to include people with a diverse range of experience in data, consumer experience, data, government programs, population health, geriatrics, diversity, equity, and inclusion, audit, human resources. Some of that is, we know what it is, but what is diversity, equity, inclusion? How do you have experience in that?
Kathy Grayson, do you want to address that or do you want me to?
I'm happy to, Delegate Collison. Thank you so much. So Delegate Krebs, we're looking for a breadth of folks that have worked with vulnerable populations in the past. We recently, as most of you are aware, entered the Medicaid market. We're now in the Medicare Advantage market. we're really covering the full array of folks in Maryland with respect to stations in life. And so we're looking for a diverse board that can speak to that. We do have some professionals in our office, for example, that really focus on our diversity, equity, and inclusion programs. They've taken on graduate level degrees in studying social determinants of health and different ways that we can be proactive. So that's the type of candidate we would be looking for in that space.
I see. It just seems like a paragraph. If you have all these things, I don't, you're going to limit your board choices directly. But anyway, I thank you for that. And thank you for explaining it. And again, I just wish in the fiscal note it had been a little more explanatory that this only applies to one board. And CareFirst, you did a great job of explaining your comparing to other big boards around the country, how they operate. So we have some frame of reference. But thank you for that.
Thank you.
Thank you, Delegate Krebs and Kathy. Delegate Morgan.
Thank you, Madam Chairwoman. I had the same question as Delegate Krebs on line, it's line 25, the diversity, equity, and inclusion. Could that be interpreted as a quota for your board?
The language doesn't specify numbers. It just specifies that they're trying to include the range of individuals. So they're looking for background experiences. There are no quota.
But how do you have experience in diversity?
Well, I think that's what Kathy was just addressing. It's folks who have worked with diverse populations, who have worked up towards health equity issues. So the experience is actually the individual having worked towards these, towards racial and social equity, not that they have experience in their own race or equity. Does that make sense?
I know what you're all trying to get at. I just don't know if that's the best way to phrase it.
So if you don't mind, Madam Chair, this is Debbie.
Yes.
So
Yeah.
Delegate Morgan, remember, we tried to broaden the scope of skill sets. Doesn't mean we have to find those skill sets. It just means before, if you looked at what the law had in terms of our skill sets, it was very specific to just being a true insurance company. It said, we want you to look for people with accounting backgrounds and information technology background and finance. Our board doesn't see us as just a true insurance company that's just paying claims. That is not our mission. And so what we wanted to do is, the board felt as though they wanted to have, if there was going to be a provision in the law that said, we'd like you to look for certain skill sets, they wanted to expand those skill sets as possibilities. It doesn't mean we're going to find people, but it's showing the breadth and diversity of types of things as we move into different markets, as we focus on the entire state, right? Our nonprofit mission goes beyond just our members. We do a lot more in the community. So this, again, is people with expertise in those areas. It doesn't mean that they personally have like you said, for a quota. That's not what this is about. They have background and expertise to help us move forward the best way we can with our mission.
Does that help?
Yeah, I mean, I guess it helps. I mean, that's I know what you're trying to do. I just don't know why it would need to be put in. I mean, to me, that's more like what you would put out there as a job offer, not necessarily something you would put in stature. But that's just my opinion.
Well, I believe what we're trying to do is make that board as inclusive as possible, as Debbie said.
Well, I mean, I would. I mean, I think in the hopes of making it inclusive, you're actually being exclusive, if that makes any sense. To me, that's an exclusionary term.
Okay.
Maybe I'm interpreting it wrong.
May I, Madam Chair?
Sure.
I was just going to say it's only exclusionary in the sense that someone with human resources experience is also exclusionary, limited to folks with human resource experience, or someone with consumer experience. We're prescribing certain skill sets that we think that the breadth of which would be valuable. And the clause is not prescriptive, Delegate. It says we shall seek to include that level of diverse experience, but it's really going to be based on the specific needs of the board. We referenced a couple times that our needs have recently expanded. We want to make sure we have expertise in Medicare, in Medicaid.
And those are all things an insurance company should have experience, and I agree. I'm just looking at it from putting somebody on the board over merit over, what might be a quota system. That's all. I'm done, Madam Chair. Thank you.
Thank you, Delegate Morgan. Delegate Bandari.
Thank you, Madam Chair. And this is a wonderful bill. If I understood it correctly, we need to expand the board of director because the company here is expanding its Medicare Advantage plan in the business. Is that correct?
That's one of the expansions, yes.
Yeah, and rather than question, not the concern as well, and the consumer members also will be increased, right, on this board?
There'll be a guarantee of at least, with the amendment, a guarantee of at least 3 consumers, and there's likely to be more. Yeah.
Wonderful bill. Thank you, Madam Chair.
Thank you. Vice Chair Peña-Melnick.
Thank you, and thank you for having me. I'm really honored to be in your committee.
Thank
I just
you.
wanted to mention that diversity, equity, and inclusion are specialists, and you can get degrees in these fields. You can actually go to school and get a degree in this. So there are people that come, like you come in with human resource experience, with medical experience. Diversity, equity, and inclusion are specialists. And a lot of people get degrees in these fields. They have to go to school to get a degree in that.
Thank you. I wasn't aware of that. Any other questions or discussions on this bill? Seeing none. Do I have a motion on the amendment?
Motion.
Move the amendment, Delegate Bandari. Do I have a second?
Second.
A second from Delegate Kelly. Any discussion on the amendment? Seeing none, Delegate Bandari, please put your hand down. Thanks. And those in favor of the amendment, please say aye.
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 Those opposed, is there any opposition to the amendment? Okay, the amendment passed. Now can I have a motion on the bill?
Second.
Delegate Bandari moves the bill as amended. I have a second from Delegate Kelly. And any further discussion on the bill? Seeing none, those in favor of the bill's amendment, please say aye.
Aye. Aye.
Is there anyone who wants to be recorded in the negative on the bill as amended? Seeing no one, it passes unanimously. And that concludes the discussion on House Bill 106. Thank you all very much. We'll move to House Bill 119. Lisa, what does this one do?
119 lowers the minimum non-forfeiture rate for a life insurance annuity policy from 1% to 0.15%. And there were no amendments.
Okay. Delegate Chi, I believe, is here. Delegate Chi is here. Do you want to speak to your bill?
Good morning, Madam Chair. Thank you for inviting me to join the work session. I think this committee has already heard our brief remarks and testimony. It's more a matter of making sure Maryland is in line with both market changes and what the rest of the country is moving toward, which is to make sure our insurance minimum rate for non-forfeiture annuities is sustainable as a product, that insurance companies operating in Maryland can continue to offer that as a viable product for retirees as an income protection mechanism, because that product does compete with other products in the market. So it's more a matter of being consistent with what the industry association is recommending as a model policy. Thank you.
Okay, thank you, Delegate. Brian Brierly, would you like to add anything?
Thank you. And just real quick, I know that we touched on this at the hearing last week. This is sort of the minimum floor that actually shows up in a calculated value. The calculation is based off of current, rates that are available in the marketplace, published rates. This establishes a lower floor than what currently is in Maryland law. This is a self-correcting mechanism as interest rates will hopefully rise in the future. The floor, the calculated value will be higher than the floor, and that will dictate it. So this bill, even though we're lowering a floor, it's part of a broader calculation that will sort of self-correct as interest rates begin to move upward again. Just wanted to add that. So thank you for the opportunity to speak.
Oh, thank you very much for being here. I see Delegate Krebs.
I just want to mention, I believe this is all prospective. Is that correct? Doesn't affect current existing contracts?
That's correct. Yes.
Yeah, thank you. And I'm not even sure how some of them are paying 0.15 because, CDs are getting like 0.05, but it's a good bill. Thank you.
Thank you.
Any other questions or discussion? Seeing none, can I have a motion on the bill?
The bill.
Delegate Kelly moves the bill. Can I have a second?
Second.
Delegate Lewis Young seconds. Any discussion on the bill? Seeing none, those in favor, please say aye.
Aye.
For anyone who wants to be recorded in the negative. Seeing no one, bill passes unanimously. Thank you all thank you, Delegate, for your bill. And we will move to the next bill. And that is House Bill 142, Delegate Amprey. Lisa, tell us what this bill does.
Sure. House Bill 142 expands the coverage requirements for IVF by prohibiting carriers from excluding expenses arising from IVF, including outpatient services, pre or post IVF procedures, pre-implementation genetic testing, and medications. The bill also prohibits a carrier from denying coverage of IVF because the policyholder or subscriber or dependent is a genetic carrier. And the bill requires coverage if a healthcare provider makes specified determinations about a patient's fertility and mental health. Finally, the bill repeals the religious exemption for coverage of IVF.
Okay. Delegate Amprey, would you like to talk a little bit about your bill?
Sure. So again, thank you all for having me today, and I look forward to this being hopefully the first of of good conversations around what we're trying to do here. The ultimate goal of this bill is just to really focus on equity in our healthcare systems. I've had friends, a constituent brought this bill to me due to her issues with the system that we have in place. I have friends, family members who have gone through the process of using IVF, and the cost burden is extraordinary. And there's also issues around equity in regards to who has access to it. So the goal of this legislation is to ensure that primarily that those who are genetic carriers of predisposed of conditions in which they are if they were to try to go through the process of getting pregnant without IVF, they're more likely for the child to have issues, the mother to have issues, and IVF is the safest way for them to go through with a healthy full-term pregnancy. And the goal of this legislation ultimately is to ensure that those individuals have that access. And we want to make sure that all those individuals have that access, no matter where they work or where they live in the state. So that's the goal of the legislation, is to open up the IVF process to everyone. And we understand that there is a cost associated with it. I understand that insurance companies are worried about the cost, but I always say to people, if you have children, and you understand how difficult it is to raise children and how difficult it is to go through a pregnancy, I think the cost that insurance companies might have an issue with is not worth more than the trauma, the pain, the heartache that families are going through with having to lose children due to having to try and have pregnancies without IVF because their insurance companies won't cover it until they've tried for at least a year. So it's important that we try to reduce the amount of pain and trauma that families are experiencing here in Maryland. And I think that because it's just such a small group of people that will constitute these genetic carriers, I think that some of the economic concerns that insurance companies have are a bit overstated. And I hope that we can come to a resolution on making sure that we are not exploding cost because we think that maybe we're overthinking how many people possibly have this issue. So that's why I brought the bill forward. And I also have my constituent who has been a great resource to us and has been pushing forward on this legislation. Ashley Esposito, she can also speak to, she helped us draft this bill, and she can also speak to some of the issues that we're trying to address here.
Thank you, Delegate. And yes, I will turn to Ashley next if you want to elaborate a little bit. We all were in the hearing, so you don't have to necessarily repeat, but just again, remind us of why this is important.
Oh, thank you. Well, as far as like the expenses goes, from my experience, before I found out that I was a genetic carrier, there were several expenses incurred just from going through the process of having babies that were affected by a deadly disease. So like one of which is like going through labor and delivery, or having to get a termination for medical reasons, and also extra therapy appointments to deal with the grieving process. I also had complications from the labor and delivery that I did have a hemorrhage. So it's like to take that risk and to take on multiple pregnancies within a short amount of time, like unnecessarily, when IVF with genetic testing could have like prevented that. We also had like an issue getting coverage for whole genome sequencing, because a lot of the tests that exist, the ones that they give you around 9 and I think like 12 weeks, like taking a sample, or even the where they take a sample from the placenta. I forget what the procedure is called, but those tests don't pick up on these diseases. So there's a bunch of costs that are incurred by not being able to like have access to IVF.
And those costs are or are not, were not covered by your insurance carrier, the costs that you were just speaking to?
They are, but they're incurred before the IVF process. So it's like I had to get all, like the insurance company had to make all that coverage plus IVF. So, it's like, to streamline the process, it would make sense that if a doctor's making the recommendation that this patient with this specific case needs IVF and this is the best route for them to take to have a pregnancy go to term, I don't think that it's the right of the insurance company to say, hey, we would like you to go through and check these lower level fertility procedures, because, there's several times where the doctors, like I witnessed them being frustrated because they're like, these people are not clinical. Like, we've just given them all this information about your case, and this is a very complicated situation. We understand that they don't understand, but for them to deny because they're trying to like save money versus saving the heartache from the patient and the extra burden of the doctors to try and like appeal, it would just make more sense to take the doctor's word for it, because it's not something they take lightly, or they just like try to pass everybody through for IVF. That's not like the case at all.
Okay. I really appreciate you being here and telling us this story. I know it's a challenge, and we do appreciate it. Questions, comments, anyone from the committee or anyone who is in the room at this point? Delegate Krebs.
Thank you. I know on these mandated benefits, we have a statutory framework in place to get them to review and evaluate the proposed mandated benefits. Has that been done yet for this?
It hasn't. And the reason it hasn't is because we already have mandated benefits around IVF. So it was looking, our first opinion has been that this is sort of an extension of that. It's not a new benefit specifically. So we haven't actually done that study. But I'm sure you've seen in the fiscal note, there's some projections around what the potential cost could be. And then, but again, the fiscal note does say it's very difficult to predict this because we don't know exactly how many people would take advantage of it. So, it's hard to predict, but there is a cost associated with it.
No, I don't disagree. I just know that in the past, that made people go through that process of getting this evaluation done, not just through the fiscal note process, but actually through the process that we determined a long time ago.
Right.
And I didn't know if they'd reached out to anyone to do that through the Healthcare Commission. It just, it doesn't just talk about the financial part. It talks about the social, medical, of the mandate. And so there's more to it than just the financial piece. So I would suggest that we would continue to follow our own statutory framework that we require for these mandated benefits and ask for that. That's just,
That would be, that's.
you and I know that these mandated benefits, they all have a heart, they all have reasons to wanting to mandate them, but we've got to look at the process we put in place.
The overall impact, right?
The impact, yeah, thank you.
Yeah, it's totally within our purview to, request that information. Ashley, did you want to respond to that, or?
Yeah, I just wanted to ask, like, if they do that analysis, can they include like unnecessary treatments that are already paid for genetic carriers leading up to that, like just to like counterbalance? And I do think that the mandate, like, because like I said in the previous hearing, because we're on paper, we're not infertile. I think this was just a lapse of like how the mandate was written originally. I don't even think they considered that this whole population needed IVF for these reasons.
Okay. We can certainly ask, our reviewers to do that, or to the extent that they can. I guess I am interested in a couple of things, and I don't know if Ashley, you want to address it, or Delegate Amperi. How would a person know potentially that they're if there are no outward manifestations of the abnormalities, the genetic abnormalities? How would a person know that they would potentially could potentially have that issue before they start trying to get pregnant?
Look, like I always say, I'm a lawyer, not a doctor. I don't want to get into the details. I think Ashley can better answer that most likely. And if there's someone else on, I don't know. I know. I thought there was someone else that's going to be on the call that had more of the insurance background on the entire process. But I'm not totally all the way sure. I know it's something most people find out as they're trying to go through the process of getting pregnant. Maybe this is also another part of this. What this bill also encourages people to start thinking about getting certain testing done before they even venture on trying to start a family. So I'll let Ashley answer the specifics on how you find out, though.
Yeah, Ashley, how did you learn that?
So our disease, as far as I know, there's only like 250-ish known cases on record. So we're literally like 1 in a million chance of like finding each other with the same mutation. Well, actually, we have different mutations. I'm the only person on record that I know of that has my specific mutation. So it really is either like 1 in a million weird situation, or there is a family history. So our disease is a recessive condition. So that means that we carry the gene for it, but we're not personally affected. But 2 copies of that gene passed along creates like an affected baby. So, there's people that do have a history of carrying things. Like I also carry a gene for like dwarfism, but I would also have to find somebody that has that same exact thing. So it can really happen to anybody. But I do know that like in certain, I guess like cultures or people from different countries and stuff, there's a trend of like certain diseases being more common to like that population. But yeah, most of the girls or people in my groups and stuff that found out that they were carriers and stuff usually found out because they either had a baby that passed or a baby that did make it to labor and delivery and was incredibly sick and ultimately had to go for IVF to have a baby like that didn't have like the same condition.
Because I will tell you, one of the things I am concerned about is the way the bill is written right now, and you sort of alluded to this, Delegate. It could mean that anyone could ask for this genetic testing. I'm gonna consider I want to get pregnant, and I want to know for sure that I'm not a carrier of some genetic disorder, and I want to go to my insurance company and have them pay for the genetic testing, which would open, while I understand that the number of people that it actually might affect is small, this bill would open up the gates for anyone to request that genetic testing, I believe. Am I right about that? I need one of my carriers to let me know whether I'm reading that correctly.
No, I don't think that's accurate because, yeah, like now you can actually order a test by yourself, like independently. I don't think that there would be like an influx of people, like some people are recommended to get genetic testing if there's like a history, but I don't think, yeah, like usually it's sparked by either like family history or like having an occurrence. Like I don't think, because whole genome sequencing is super expensive and most insurance, that's a completely separate like process. I don't think, like not everybody that gets IVF gets whole genome sequencing.
Right.
That's only for the specific people who need IVF that have a rare condition that's not picked up by the lower level tests.
And I can only speak to my experiences. I had to get genetic testing because of my wife's family I think they were a genetic carrier of the sickle cell trait. So we had to get certain genetic testing before our doctor would, encourage us to go through with starting a family. So it's not uncommon that people do certain forms of genetic testing, especially if they have certain family histories, or as Ashley spoke to, we know the sickle cell trait is mostly prevalent amongst the African American community. We know there's certain traits among certain ethnic groups. So the ability to I don't think there's anything new around testing, and I think that ultimately, I think what Ashley has described here, as far as her entire experience, I think the testing process would be a cheaper, more efficient way for insurance companies, because they would know beforehand what's going to happen before. If people aren't getting tested, you go through the process of more. First of all, I think about the pain and trauma of going through whatever you have to go through, but ultimately also save money if we know everything beforehand, before we have to go through the issues that might happen if you are found to be a carrier while you're pregnant. So I think the concern there is real, Delegate Colson, but I think there's ways in which we can possibly change some language to make it so that we're thinking through to make sure we're not opening up it to a point where everyone can just claim something, but they have to actually get certain testing and tests.
Matt, are you raising your hand to respond, or is that you're just lifting your pencil? Okay.
I have plenty to say, but I could wait my turn.
Well, okay. But while I have the little green box around you, let me ask you, in the case of that the delegate was describing, where his family history might include sickle cell, here's his partner, is there currently, what are the current statutes around if there's a possible genetic predisposition?
It is my understanding that would be medically necessary to get the test, and it would be covered by the carrier already. So there's a bit of like confusion going on here, I think, and I don't think really speaking to what the bill does. But if we get to the next part, before I say anything else, I just wanted to say, Ashley, I totally understand the suffering. My wife and I have 3 beautiful children, but had a bunch of miscarriages, and the pain is hard to quantify. So please don't take anything I'm about to say as an attack on you whatsoever, please. I think that there's sort of a misconception with what's going on here with this bill. And a lot of the testing that has been discussed is already covered, but there is a cost impact to it that has to be thought about. And as you would imagine, the IVF mandate is sort of like the Everest of updates or of mandates. Normally, when the General Assembly moves on a mandate, we're talking about 0.1, 0.2, 0.3% premium impact for some of the more expensive ones. IVF can be pushing 3%. It is the mandate that has the most impact of premiums. Not to say that we shouldn't have this discussion, I'm just saying that it is a cost factor that even if we were to modify the existing mandate, we believe that the MHCC should take a look because it will have far-ranging consequences. And as you will see in the fiscal note, just DBM's analysis of state employees alone, if we're talking about between 20 and 100 people, a small piece, we're looking at between $500,000 and $4 million annually. So this does have a large impact. And just to address one or two other things that Delegate Ampry had mentioned at the beginning, that we certainly don't want anybody to experience a miscarriage. That is it's an awful experience. I can tell you from my own experience. But even with IVF, miscarriage actually happens with IVF more often than without IVF. So it's not going to sort of alleviate that suffering that comes with miscarriage, even with an IVF benefit extended. These are just discussions that are really difficult, but I want to make sure that we have the discussions, we realize the impact of the entire market overall.
Thank you, Matt. Laura Bogley.
Thank you, Delegate Collison. I'm not familiar with how you manage your subcommittee, so I don't know if there's going to be another opportunity later on for opposition discussion, or if it's open-ended, if
open-ended.
Okay, great. Thank you so much. So Maryland Right to Life, as I said in committee, does not take a position for or against IVF, but obviously there are moral and ethical issues in the practice of IVF. My interest here is trying to find out from the sponsor of the bill what the necessity is to remove the religious exemptions for providers and religious organizations who would choose for moral, ethical, or religious reasons not to participate or fund IVF. It seems to me that that provision would be unconstitutional on its face. And it may be destructive to the sponsor's intent of the bill if he truly wants to have this bill progress through the House and Senate. It would seem that removing that unconstitutional provision and just dealing with the cost increases for insurance providers, other than those with religious exemptions, he may have more likelihood of success of actually helping the people that he needs to help. So I don't know how many people will be impacted by the religious exemptions for IVF. I do know that Catholic hospitals in Maryland provide very much needed services to poor and underserved populations in this state. And through this bill, we're not going to see those hospitals compromise their religious tenets. What we'll see is fewer providers providing needed health services to pregnant women. I don't think that that's the intention of the bill. So I would ask the committee to really closely look at that. You know, we have federal precedent, both case law through the Supreme Court that says that you not force providers or not provide the religious exemptions for providers with healthcare for things like contraceptive care. So I think this would very much be considered by the court within that same nature. We also have federal regulation, the Religious Freedom Restoration Act, that specifically prohibits both federal and state governments from not providing those religious exemptions for bona fide religious beliefs. So I just think that that's, counterintuitive to what the sponsor is trying to achieve. And since none of the other delegates on this subcommittee asked the question, that would be my question for the sponsor. Does he think that forcing religious organizations to participate in IVF or provide coverage for IVF against their constitutional right to the free exercise of religion either advances the people that need this help or hurts this bill? Thank you.
Yeah, I guess can I answer this directly, Madam Chair?
Sure.
Yeah. So first of all, I don't want to. I'm very respectful of religious organizations, and thank you, Laura, for your fierce advocacy. I appreciate it. And at the end of the day, I think ultimately we still need to talk to to Mr. Frosch and his office and discuss the constitutionality of that provision in the bill. I think in my mind and my legal understanding of the exemptions that are put in place, I think here it's different in that the genetic carriers, it goes beyond the person's inability to carry a child. It's more so that a child could be seriously harmed or hurt without IVF. So I think that the constitutional analysis, I will rely on the Attorney General's look at this. I'm a transactional corporate attorney, so the constitutional stuff isn't what I do every day. So I think our goal there, again, the goal of the bill is to bring just more equity and opportunity for everyone to be able to have a family as healthy as possible. That's my goal, and I think that ultimately, I just want happy people and happy families in Maryland and in my district. That's my goal here. So, but if it is found to be unconstitutional based on that analysis, I think it would make the most sense to take that part out of the bill upon a full constitutional review by the general attorney, by Frost's office. So I'm on board with you there. That if it is unconstitutional, then I think that it would need to be removed. I'm not trying to do anything unconstitutional, and I don't think the committee would vote on anything unconstitutional.
And we appreciate your participation, Laura, and your input here. It's really helpful. I'm going to call on, I have 3 more folks to call on, and then we are going to close for today. Remember, this bill, we will continue to work on this bill and bring it back to us and after we've had some additional consideration. Kim Robinson.
Is it still morning? Good morning, Madam Chair and members of the Insurance Subcommittee. I'm Kimberly Robinson with Cigna. Thank you for the opportunity to participate. This is a really emotional bill for a lot of different reasons, and I definitely appreciate Delegate Ampry, and I've lost her face to call her because I don't know you, and I don't want to call you by your first name, so familiar. But Ashley, because I can't spot your last name fast enough to call you Mrs. But for bringing the bill forward and starting the discussion. I wanted to go back and ask a specific question that you asked Delegate Cullison, not so much about the intent of the bill, but how the bill is currently written. And you had asked about sort of the scope of executing the bill and what it would take for an insurer to comply with the bill as it's currently drafted. And I do think that from our reading of it, I don't know that the bill is as crafted to the intent as it could be. In order to comply with the bill and identify who is eligible for its benefits, I don't know that you get around having to interpret into the bill, everyone gets genetically tested so you can figure out who those individuals are. Now, I don't think that's how it's being envisioned by the proponents or the sponsor, but I do think that as it is written today, it's hard to operationalize without making that the starting place. Delegate Krebs talked about our mandate review process, and while it is not a full new mandate, you're right, we already have not quite unique, but one of very few mandates in the country that requires insurance coverage of IVF whatsoever. It is, particularly as it's currently written, a particular kind of shift. And I think one of the things that we struggled with as we went to try to evaluate the bill is how we connect it to the current standards of practice. I know that the provider community doesn't always appreciate how the medical necessity rules for carriers are created, but just to make sure that this committee and those who are not on the committee on the phone have a little bit of perspective about that. Maryland has a set of laws around this that are very consistent with what carriers were doing, even outside of the laws specifying so, but our medical necessity criteria are based on the practice of medicine. They are based on standards created by practicing physicians and others in those specialties that those criteria apply to. Maryland's law sets requirements for what medical necessity criteria must be, that it must be rooted, in the practice of medicine, that it must be flexible, that there's several criteria that it has to meet to be used in the state to ensure that any evaluation we are providing around what is a covered service and what isn't is not being done willy-nilly. The people who make those reviews for us have to be providers. It's not business people who are making those decisions about what's covered or when a request comes in. And so I think that it's important just to create what that framework is. And I think what has been challenging on this bill, unlike the mandate as it stands today, the mandate as it stands today follows the American College of Obstetrics guidelines for when someone is being referred for IVF. So when it talks about those current standards, that's where they were derived from. And I think there's a conversation to be had about what are the genetic conditions we're talking about. The language is very broad. Every genetic condition is not going to have this impact on fertility. I think it would be helpful to be able to use the interim and do that kind of evaluation to understand exactly who are we talking about. What are the conditions that really impact fertility, conception, make IVF a in fact, perhaps a better attempt to carry or to screen an embryo, whatever it might be, and write a bill that really speaks to who truly needs it, as opposed to broader language that creates all of these uncertainties, these questions that might narrow a fiscal note, that might have a different impact. I think the bill as it's drafted today, not being based on specific standard of practice medical criteria, is what is causing some of the challenge around it. And I do think that the Healthcare Commission's process would put it in a better place to help advise the committee, to help shape the language of the bill, and to give that perspective, because this is really important, but it's also important that we get it right, that we're doing it in such a way to help the people who need to be helped, and also not creating a financial burden on them and others by inadvertently inflating a premium that's not the intent, and is doing things that aren't what's being intended in that process. And so I do think that there's an opportunity for the committee to use your own mandated process to your advantage, to better understand this, and to make sure we all understand the best way to make this work.
Thank you, Kim. I appreciate that. Good information. Delegate Bandari.
Yeah, thank you, Madam Chair, and thank you, Delegate Ampry, for the bill. The intention of the bill is wonderful. To bring the perspective of Madam Chair Bonnie's question. I know, Ashley, as you mentioned, that IVF, this can be very time-consuming, expensive, and very invasive. And sometimes when we are writing the bill, we need to aware of the safety issues as well. Sometimes if more than one embryo is transferred to the uterus, IVF can result in a pregnancy with more than one fetus, that multiple pregnancy. And when we're talking about the language, I think we should be aware that how before we have this procedure done, how less invasive treatment before attempting IVF is made, including the fertility drugs, because there might be different issues like fallopian tube might be damaged, ovulation disorder, impure sperm, or endometriosis. Those, if the constituents or consumer goes through all these things. So I think we need to narrow the bill a little bit. I do agree with one of the advocates here from Cigna as well. Thank you.
Thank you, Delegate. So Ashley, you're going to get the last word for today, and we only have a couple of minutes. So
yeah, I can just tell by like some of the conversations and stuff. Like, there's a lot of confusion about like what our specific issue is. Like, we do not have infertility by any means at all. Like, we can get pregnant naturally. We can carry to term. All we needed was a healthy baby and like a healthy embryo. And also, like, when it comes to the idea of the bill initially came from my doctors, because my doctors, who were specialists and geneticists in treating patients like me and my family, they said, oh my gosh, the insurance company denied it again. This is just another thing. Like, luckily we're used to doing these appeals, so we know how to do them. So it actually was sparked by them and the extra burden that they have to do, and the extra heartache that it caused us by receiving the denial, and them trying to calm us down and say, no, this is a lapse in the mandate. So, and also it was something that was experienced by people in my genetic carrier group. So we don't have infertility. I didn't have a miscarriage. The 2 pregnancies that I had, one passed away. The other one we terminated because it was very severe. So it was the most compassionate thing that we could have done in that situation. And so, I don't know, I guess like my last words would be to, when everybody's talking about the cost, please factor in what it would cost to have 2 pregnancies go to 20, because this is my case, 2 pregnancies go to 20 weeks or further within 1 calendar year, plus weekly therapy appointments, plus FMLA leave, and all the other OBGYN appointments, lab work, everything, and see if that matches up to a cycle or 2 of IVF. Because I think the reason why the insurance companies aren't connecting all the dots is because all these things are billed separately, but they're all incurred for the same reason for patients like me.
Thank you very much. I appreciate you being here and giving us that perspective. I'll thank the committee for the completion of our first meeting of the 2022 session. Please watch the MGA website for further scheduling. And we know that we're going to be working on this bill over the next few weeks to see what we can do, if there are pieces of it that we can help reach some resolution on. Okay. With that, thank you all very much and have a great afternoon.